you've heard all the good stuff, really, and I've got two tasks I see at this meeting. The first one, I'm going to look at the political side, because that's where I think there's something happening, and we've made something happen. And then I think we want to look at the scientific side, which I'll look at more tomorrow. So if you're disappointed today, come tomorrow and you'll be all right. And I'm not trying to be an expert. I'm wanting to elicit from you suggestions and ideas. And if you say he's missed something out, well, I'm sorry, that's my limitations. But you still have a chance to contribute at some part in the programme. The Gibson Inquiry, there was a big debate in the bureaucracy in the House of Commons as whether this was a parliamentary inquiry with a big P or a little p. And I thought, God have mercy. I really feel if that's the level of argument and concern, it turned out it's a little p. So there you are, we're all little p's. But concerned with research programmes, treatment, definitions and diagnosis, so we'll look at this. The Gibson Inquiry starts, this is where we start, I think, today. This, terms of reference were to increase public understanding of scientific research into ME and CFS. So it's increasing public understanding and awareness, I think, ought to be added there. Evaluate progress in the development of a full programme of research, and we're doing that already. It's a good programme, it's a big programme, but it's a small, in terms of numbers, programme. So we're beginning to get the data that Vance is so keen to get, and he's absolutely right in that. And identify research funding and requirements in establishing the cause of ME. Well, there's a lot of arguments about cause and causes, and there's a lot of escape routes for people who say there's no single cause. No one's saying there is. So why do we find ourselves in this sort of situation? Substantial research monies have gone to to the psychiatric, psychology, biopsychosocial lobby to provide clinics and current studies, which I said some trenchant things about this morning, because I do feel these are failing patients. And they are controlling the agenda as well. So we're looking at definitions, causes, diagnosis and treatment. Not all today, you'll be happy to hear. But the Gibson Inquiry was looking at these things, and it also finished up with a very strong emphasis on the Canadian criteria, plus medical education. And I was delighted to hear Dan saying that this is a thing that they're moving towards in the States, to endorsing these and using them and agreeing to use them across the board. If we could get that single agreement, that would be a big, big help. The NICE guidelines are inadequate. They're still being debated. We're putting a lot of protests, and a lot of people put in a lot of protests. And both the MRC and NICE have failed to pick up the challenges at the end of the CMO's working group report, which was rejected by the psychiatrists and by the 25% group, so you can judge how important that's going to be regarded. And then there's the impact on the benefits and insurance industry. Gibson was right, and he did us a good service by identifying all these areas in regulation, in terms of vested interest, protection of money, and the need for good research and a wider public understanding. So it was a good start. This is really to make the point about political. It doesn't matter where you belong. It was great to have Norman Lamb here. It will be great to have Ian Gibson here tomorrow, representing two different political parties. And this is really a repeat of what I've already said. How do we build on it? Well, I think political action involves... I'm not good at political action. And many of you are not. And many of you haven't got the energy to do it. But your supporters do have, I think. And we need to get hold of MPs and nail them down and say, this is what we want to talk about. And this is what's happening. Tell our stories and tell your stories. Individuals and groups, as well as the all-parliamentary group has already been mentioned. That represents a way in. Individual MPs do. The Minister of Health does. And there are people operating at this level, people like Ian Gibson and Norman Lamb, but others as well, Countess of Mar particularly. How can we best support their efforts? So there are people there that we can use and be conduits for us, and they're willing to do that. The next thing is changing the mindset of politicians, the NHS and clinicians. Last year I told the story of the debate in the House of Lords that was led by the Countess of Mar, where the government has signed up to the World Health Organization, ICD-10, that ME is neurological. I know it's lots of other things as well, but that's a starting place. That's where it was placed. And the government has signed up to this. They're now trying to backtrack. Well, we agree that's the definition in the WHO, and we agree with the WHO definition, but we think they've got it wrong, is the sort of subtext that they're writing. So they've been very unwilling to admit this, and the story I told last year is still one there's been no real action. But parliamentary debates do take place, committees do meet, bills are enacted, and ministers can be challenged, and they have been. But much of what happened is still extant. The feeling and the viewpoints are still there, as it is inside the NHS. This is I'm not a salesman for quotable quotes, but it is a valuable resource document that's available, and it's providing profits for research into ME. And this is Margaret Williams' latest work. She's a tremendous worker. She's got ME, seriously got ME. She's a 25% group person. And she's quoting from experts in inverted commas, because these experts, as Byron reminded us last year, were people who don't examine patients. As a matter of principle, we don't examine patients. So, I mean, what the hell is going on? So we owe Margaret a great debt, and I just want to acknowledge that publicly, really, because she's put this out under great challenge, really. But can we collect similar quotes about what patients are experiencing from the present clinics? Now, John Sayer in Norfolk has started doing this. He's looked at the criteria for appointing people to these clinics. What do we want from this? There is a further warning of possible danger involved in the job. The patients might get very upset. They might be demanding. But you're involved in people who are perpetuating illness behavior. The trainee clinical fatigue therapist will require to modify predisposing personality style. What a funny lot you are. You will experience barriers to understanding. Well, not surprised, really, because we don't agree with that. That's not your experience. They're not hearing your experience. So it's not you who are not hearing their spiel. It's they who are not hearing your spiel. So we need to tell our stories. And it would be quite useful to put a similar book out on the stories from the clinics, really. And we've all got them. We need to continue to press for the Canadian criterion guidelines to be adopted nationally. Diagnosis, as has been said repeatedly by everybody, is crucial, and misdiagnosis is common. So many people are getting placed in the wrong place, and this is what confuses the whole scene, that we're seeing people who have not got ME, we're seeing people who've been misdiagnosed with other illnesses, and top of the list, I think, is hypothyroidism, and the thyroid is a big player in this, but there's other things as well. ME is a multi-system, multi-organ, complex biological illness. It's a whole body illness, as we heard earlier from Dan. Subgroups are necessary because to find out what's happening with people, you find that some things are affecting some people and some are not. Some people have severe pain. Some people have little pain. I was just talking to a brother and sister who have this contradictory appearance in the expression of their symptoms just over lunch. And Byron, who is Nightingale Foundation, sorry Byron, I've blown your cover. This definition is very valuable and very helpful, and it's with your pack, and it emphasises the role of infections as an initiator of ME, but recognises the impact of chemicals and other environmental triggers. I'll say much more about this tomorrow. Very much in agreement with the Canadian criteria as I read it, and I may have got it wrong, because I'm not a clinician, and Byron can speak here and correct me if he feels that's necessary. But it would be valuable to see how this relates to the Canadian criteria. But the great thing out of Byron's definition is that it emphasises early diagnosis, because that's the time to get in with effective treatment. That's when treatment will be most effective. I was in Australia just recently, where Dan and Kenny were there as well, and Henry Butt and one or two other important people in this field. And it's good to acknowledge here the Alison Hunter Foundation, where they've fought a battle in Australia and New Zealand, which we are fighting here. And they're beginning to make progress. And so we owe Christine Hunter a great debt. And she's put a huge amount of personal funding into this and to get people together to talk about the issues in MECFS. And this is taken from her conference brochure, which just at the end of March there. And it's taken from the IACFS Statement in 2004. This is what we're dealing with. Very sick people, many not diagnosed or treated. The strongest predictor of post-infection illness is the severity of the acute illness onset. Psychological factors play no role in this development of CFS. Can't say it more plainly than that. And they're into research, information, and advocacy. And I would add to this for education. And those were the important guys who were there. They were the Lord Mayor's show in Adelaide. And they always need someone to clear up at the end, so I get the job. We need to change the system of research funding by the MRC and other bodies. The present system does not allow, as you've heard from Vance and you've heard from Jonathan, high-quality proposals to be funded. The MRC classification of ME involves psychiatrists whose ideology, and it's an ideology. It's not a science, it's an ideology. We believe this. I believe you are mistaken about your disease. Where's the data? Where's the facts? And so biomedical research comes, as Vance has reminded us, very low down on the scale. So there's little support, good quality research goes unfunded, and this is an all-pervasive problem, as Jonathan emphasised this morning. So we are calling for a different system in which biomedical grant applications are referred to a newly established MRC panel or sent to specialist panels in the appropriate subject areas, neurology, immunology, cardiovascular, etc., in which no psychiatrists are involved in making a judgment in these areas of expertise. And that would be one way forward. We have suggested this to Ian Gibson, and Byron's been very much part of all this exercise. Research proposals have to be refereed. Vance is absolutely right about that, and you saw that he exercises that responsibility. The high quality of recently published studies in the ME is testimonial to the sacrificial support of ME community. This is sacrificial giving that you give to support this work. And the quality of the research that's been completed is very high. These are achievements that are behind us. We can point to these achievements now and just say big thanks to everybody who's done this. This is not easy. It's not easy to plan a research proposal. It's not easy to carry a research program. It's not easy to write the paper and get it published. My paper from last year is about to be published, I understand now, but the lawyers tried to block it. What they've got to do with it, I don't know. But people are getting very nervous about these things. Sarah knows all about this. So that's an issue. Areas of important research already established. I'm sorry, Vance, I should have talked to you about this. This is all Vance's, and he's going to talk about it tomorrow. But I've just flashed these up to show that this is a list of the sort of work that's been done. 1, 2, 3, 4, 5, 6, 7. And it still continues. And this is published work in high-quality journals. This is top-class work. And Vance has done a fantastic job here. This is Vance and his Merry Women. 3 cheers for them. They've done a terrific job for us. And then Jonathan comes along with his gene expression. This is groundbreaking. This is detailed, careful study, providing enormous amount of information which can be built on, and suggests more and more ways in which we can develop research. And people like Sarah are picking up on some of these. Sarah's stuff on mitochondria is being validated by the gene signature that Jonathan found in his work. And we need to learn from others. And it's great to have Kenny here. And we had Bruce Carruthers last year. We've got Byron this year and last year. And we've got the Norwegians coming in who are doing great things in the political sphere. And with Ellen Piron, we're going to hear from her later. But these are ongoing projects. It's not stopped. These are achievements in the past, but these is more to come. And there's new faces popping up from Newcastle, from Glasgow, from Belgium. We are developing, or Vance is developing, to be fair, a network for future research activities. That is in place. These people have picked up the challenge, have seen an interesting and challenging research program which will give helpful information about the condition called ME. We're wanting to establish centres of excellence, and that's why I was so keen to meet Annette and Dan today, because they're doing it. They've done it. Does this centre give us a model, a viable model, for something that could happen in the UK? Do we have to tweak it in different ways? But any centre in the UK must have expert clinical staff. It must contribute to medical education. It must have prompt access to appropriate and advanced testing. It must be fully funded nationally, some way or another. But there must be significant national funding. We need to replace the present clinics that are psychiatrically based, and we need to provide a clinical expert service to the housebound and bedbound, the 25% group, who are never seen. And in fact, getting to those is going to be difficult, and it needs to be free of political interference. I use political with a small p this time, clinical or medical or otherwise. Insurance and benefits, we've got to identify and remove, as Gibson said, vested interests and malpractice. And Byron's going to be talking about that. And the so-called experts who don't examine patients need to be challenged with real evidence. And it's emerging from the work that's happening in this country. We can latch on to the stuff that's coming out from the States and other places, but it's happening here as well, and it needs to continue and develop and expand. Alan Gould-Smith published a short paper showing the bias in publications in clinical journals towards the biopsychosocial. It's the whole process and the whole system has been corrupted by this bias, and we need to be able to speak against that. The other thing is already being mentioned is Munchausen's syndrome by proxy. Sectioning of people is still happening. I got rung up just this week by a lady whose daughter's been sectioned at 11 o'clock at night, taken into the local mental hospital. And we activated all systems. She's still in there. The College of Paediatric and Child Health needs to be reminded of its own comments about this. We believe that far more children and young people with severe CFSME fall into the category of a child in need rather than in danger. A referral to social services is likely to be destructive if based on flimsy or ill-reasoned evidence. Where is the evidence? Have we got the evidence? Fancy's absolutely right. So we need to challenge and provide sound evidence. And you will listen to it to this conference. You're privileged to listen to it. And we need to learn how to use it. We need changes in the contemporary views in medicine. Ideologues versus clinical and scientific studies. Ecological, complementary, integrative, holistic medicine. That's what's needed, because it's a whole body issue. Knock-on effects for patients are prescriptions. Can you prescribe the drug? Are you allowed to prescribe the drug? Has a patient got to buy it privately? That's usually a huge expense. There's no support for supplements, despite the fact that I've missed out the fatty acids here, but many people find them helpful. High-dose vitamin 12 is used, but I know a local doctor who's being castigated for giving high doses of B12. It's outside the criteria for prescribing. Hounding of doctors who will challenge ideology or practice. Well, there's a list of them. Wakefield, Sarah, who's here, Peatfield, Chandy, Skinner. There's a whole row of people. The establishment does anything but attempt to replicate their studies. As Vance was saying, have they replicated the brainstem studies? No. Why not? They're important studies. And I call it tick box medicine at arm's length. And if people find that insulting, well, you can tell your stories and see whether you agree with that. And Byron, at the last day conference, produced this pamphlet, which was nobbled by the lawyers, about the stories of the origins of the psychiatric derivations and psychogenic origins of ME. And this is Sarah's plea, and it's a plea I'm making on her behalf. She doesn't know about this, so she'll probably kick my shins afterwards. But she's been hauled before the GMC. Why? No complaints by patients. It's by doctors. She's been clobbered so long that she's got to defend herself, do-it-yourself stuff. She's been prescribing thyroid hormones to patients with normal levels. She's backing her clinical skills against the biochemical tests, and a good clinician should do that. She's been accused of using tests for mitochondrial failure and prescribing accordingly outside of her area of expertise. She's seen hundreds of patients. So what is expertise? Using magnesium sulfate injections for treatment. Most ME patients have got low magnesium levels. We know that. And we could actually do a useful study on that. challenging orthodoxy with regard to prostate-specific antigen test, which is a very poor test, and everybody knows that. Use of biolab for a vascular screen and for other tests. Well, that's the only place you can get the test done. Non-standard treatment of depression. So how to support her and others like her? Do we want to make a statement from this conference? Do you want to say that we support her from this as a conference? Well, let's do it then. We can put something out and get people to sign it up, and that shouldn't be difficult. Thyroid UK, and this is Barbara who's given me this information. I've just pushed it in. Have coordinated support for doctors targeted by GMC. Contact them for details. So Thyroid UK are also onto this as well, because this is not good medicine. It's not patient-focused. It's cost-focused. And we need to be just aware of what's happening. The CFS toolkit for healthcare professionals from the CDC includes a toolkit for cognitive behavioural therapy. So there you go. We just need to be a little bit careful about those who get into our bed, as ever. And it just seems to me that we need to just be aware of some of these things. And tomorrow we'll look at diagnosis, understanding and treatment. Thanks very much.
Thank you.